Hi everyone, I'm Bahesta, so I'm the teaching lead along with Carla this year. I think we're just going to give the lecturer a few more minutes for him to join. I think he's in the waiting room actually, and then we can get started. Hiya, Dr. Melo, can you hear me okay?
Can you hear me now?
Perfect. All right, I still have a few people joining, so we can give them, let's say, a minute or two, and then we can get started. Is that okay?
Of course, no problem.
Perfect.
I just share my screen to make it easier.
Perfect. Okay, we've got 30, so I think we'll get started. So
Okay,
hi
yeah.
everyone. So for most of you, also be your first time seeing me. So I'm Baheshta. I'm going to be the teaching lead alongside Carla this year on OxPal. So welcome to the Obs and Gynae lecture series, and thank you for coming to the first lecture. So today we have Dr. Pedro Melo, who's going to be doing a lecture on infertility for us. He studied medicine in Paris and Lisbon and then obtained a master's from Oxford. And he also has a PhD in reproductive medicine. But I'll also let him introduce himself as well. But I hope you will enjoy the lecture. And then after the lecture, we will be sending out the workbook that Dr. Melo has kindly put together with a number of cases that you can work through. So yeah, enjoy. I will mute myself and I will hand over. Thank you.
Thank you so much, Mahashta. Everyone, hi. It's nice to see you all. Although I don't think anyone has their camera on, which is fine. It's not a problem. My name is Pedro. I am a gynecologist working in the UK, and I subspecialize in reproductive medicine, and I spend my time dealing with people with infertility, miscarriage, early pregnancy issues, all sorts of reproductive medicine problems. I'm going to share my screen, which I hope is successful. Can you see my screen?
Yes, we can.
Oh, great. Thank you. Okay, lovely. It would be really nice if we could make this interactive. Because so usually I'm going to give you the same lecture I usually give the Oxford medical students in their 5th year. And I usually try and make it as interactive as possible because I think well, to me, it's such a fascinating topic that I enjoy the discussions that arise from the lecture. So by all means, if you have any questions at any point, just stop me and ask the questions, and we can have a chat. So usually what I do when talking about fertility or infertility is really number one to try and relay to people how impactful infertility can be in individuals' lives. It can be truly devastating, not just from the standpoint of dealing with infertility from a physical standpoint, but also the psychological impact and the widespread impact that it can have on people's families, people's jobs, and also healthcare services. And the point of today is to talk about some of that, but also talk about the causes of infertility and various ways in which we can tackle each specific cause as well. And something that is very specific to the UK is the Human Fertilization and Embryology Authority, which is essentially the regulator of all fertility services in the UK. And I think that's probably outside the scope of this lecture. But if you do have questions about that, we can talk about it. I think it's important to realize that having a child is, to many people, one of their most profound aspirations in life, really. And I think what I've come to appreciate over many years of working in this field is that it really takes going through it and living through infertility to be able to appreciate how absolutely devastating it can be. And the WHO defines it as a disease, and it has a very heteronormative and binary definition of infertility because it essentially takes into account the fact that people are diagnosed with infertility once they've tried to conceive a pregnancy for 12 months or more of regular unprotected sexual intercourse, which they assume, will be vaginal intercourse. And it is something that, as I said, a huge impact on people's lives, and it is considered a disability as well. As of late, as times have changed, there have been newer definitions of infertility, particularly from the American Society of Reproductive Medicine, ASRM, who now consider infertility to be any condition requiring medical intervention to achieve conception. So a slightly different definition compared to the more conventional one. And what we also know about infertility is that it's incredibly common. It affects about 16-20% of people. And it's really interesting for me to see things in the UK because in the UK, IVF cycles are, to some people, funded by the NHS, the National Health Service, but not universally so. And what we have seen over the past 5 years or so is that the percentage of cycles that are funded by the NHS has dropped massively to the point where most people now have to pay for their own IVF. And when I think about causes of infertility, can anyone tell me about, broadly speaking, some causes of infertility?
We have male factors and female factors, so it depends.
Yeah, I agree. What sort of female factors can you think of?
For example, PCOS
Yeah, which leads to what?
and ovulation.
An ovulation. Yeah, I agree entirely. And I see that so I've got the chat box in front of me. Sorry, I'm using more than one screen. So I can see that you got PCOS and ovulation, hypothyroidism, yeah, endometriosis. And so any more? Any other causes of infertility?
Structural abnormalities when it comes to fibroid, polyps, and other things that can cause adhesions that can close the channel to actually do implantation, maybe.
Yeah, absolutely. I agree with that entirely. So fibroids and polyps can have an impact on the endometrial lining, whereas, as you said, adhesions can have an impact upon tubal obstruction. So that can be detrimental to fertility. And hyperprolactinemia is something that Zara has just put on the chat. Yeah, I agree. Hyperprolactinemia is one of the causes of anovulation, and it can stop people from releasing eggs every month. Chemotherapy, yeah, chemotherapy is important. What does chemotherapy do? What does chemotherapy do to you?
I
Yeah.
think the whole principle of chemotherapy is killing rapid cells that proliferate. So that's maybe the reason why eggs, when they actually try to conceive and everything, the cells won't proliferate as they should, and that can cause those congenital abnormalities.
Yeah, absolutely. So chemotherapy it can lead to congenital abnormalities, but most importantly, in the context of infertility, it can really lead to a complete depletion of the pool of primary and primordial follicles in the ovaries. So it can really lead to premature ovarian insufficiency in people who undergo gonadotoxic treatment, which can be chemotherapy or radiotherapy. It doesn't matter. You've got quite a range of suggestions here. So biological anomalies in the reproductive system. Yeah, I agree. So Mullerian duct abnormalities can lead to difficulties conceiving, depending on where those abnormalities are. People can have, you know, an absent womb, for example, in MRKH syndrome. Very low BMI, yes, very low BMI is known to lead to centrally driven anovulation, so hypothalamus-driven anovulation with a lack of GnRH, FSH, and LH. Premature ovarian insufficiency, which is something that we just alluded to. Does anyone know what the definition of premature ovarian insufficiency is? What we use to diagnose it?
When there's like menopause before the age of 40, mainly with the
Yeah.
other investigations, let's say.
Yeah, so usually people present usually with at least 4 months of amenorrhea, and also an FSH level that is usually above 25. Before, we used to tell them that they had to have 2 different measurements of FSH above 25, 4 to 6 weeks apart, because that's what the ESHRE guideline. The ESHRE is the European Society of Human Reproduction and Embryology. So that guideline stated that that's what it should be. There's been a guideline on POI that's just been updated, and it basically states that we no longer need 2 measurements. But you're absolutely right. Premature ovarian insufficiency happens in people younger than 40 years, and it affects about 1% of the population. Athletes too, this is true. And again, athletes are affected by a very low percentage of body fat, which can have a huge impact on the hypothalamus pituitary ovarian axis. Uterine anomalies, yeah. Ovary stop function for 40, yeah. Bicavitated uterus, yeah. So that all falls under the uterine congenital abnormalities. How much is considered a regular intercourse? So regular intercourse is generally considered every 2 to 3 days. It varies really, because it's a little bit unhelpful to tell people, oh, just have sex every 2 to 3 days and trying to conceive, particularly if they've already ovulated and they're like in the luteal phase. So it's less helpful around that time, because how long does sperm live in the reproductive tract? The female reproductive tract?
3 days.
72 hours.
Yeah, 3 to 5 days, absolutely. 70 to 250, 220 hours. Whereas, what's the lifespan of an oocyte, of an egg?
24 hour.
One
Yeah,
day.
more or less. Yeah, definitely. So what we want in many ways is for sperm to be in the reproductive tract, in the female reproductive tract, already by the time the egg is released. So when I think about causes, and just to sum it up, in my head, I think about causes in a very, very, very simplistic way, which I think is helpful though, because it makes me, not forget things. When I think about making a baby, what I think about is, well, number one, do we have ovaries? That's important. Secondly, do the ovaries have a good ovarian reserve? And that's something that we can test with blood markers, but also ultrasound markers, and we'll come to that in a moment. The third question I ask is whether people are releasing eggs every month, whether there is evidence of ovulation, and there is a plethora of conditions that you've mentioned, like PCOS or hyperprolactinemia or hypothyroidism, that can stop people from releasing eggs every month. And of course, if an egg isn't released, then it can't meet the sperm. The egg will meet the sperm usually in the outer, or the junction of the inner 2/3 and outer third of the fallopian tube, and then which is the ampulla, and then if it is fertilized, then it will make its way down the fallopian tube over the course of 5 days, and it is now called an embryo once the egg is fertilized, as you'll know, and that embryo will attach itself to the lining of the womb or not. And if it doesn't attach itself, then it'll come out, and people won't know any better, because they'll just have a period as they should do. But in that journey, what we need is to have open fallopian tubes, which is what we can see here. And of course, we need an endometrium that is receptive to the implanting embryo, which is the way we assess fallopian tubes involves dye tests a lot of the time, which we'll come on to. The way we assess the uterus involves 2D, but also 3-dimensional ultrasound, which can be really helpful, particularly in identifying polyps and fibroids. And finally, we need sperm that comes into the female reproductive tract through the vagina with unprotected intercourse. I'm going to pause there. Do you have any questions so far? I'm just looking at the chat. Okay, this feels fairly clear, and I can tell from with the answers I've got, I can tell that your level of knowledge is pretty advanced already, and yes, which is really lovely to see. I hope this is not too basic for the audience. So when you think about causes, as I said, NICE, which is the National Institute for Health and Care Excellence in the UK, has a guideline that that basically details causes of infertility, assessment, but also treatment. And what we know is that the most common cause of infertility or isolated factor is male factor infertility, which affects about 1 in 3 couples. And then after that, you have unexplained infertility, which affects 1 in 4, so no obvious cause. Ovulatory disorders like PCOS, again, 1 in 4. Tubal damage affects about 1 in 5 people or females. And then uterine and peritoneal disorders like endometriosis will affect about 10% of individuals. No, can anyone describe this to me? Do you know what this image depicts?
Is it the IVF?
Yeah, I mean, I think it is something that it requires IVF for sure, and I can see where you're coming from. I mean, it is something that is done for when people have IVF, not always, but sometimes.
I think I've seen a video about putting the sperms in the ovum in the labs or like outside the body. So I think that's the procedure that they are trying to do.
Yeah, that's what I thought as well when I first saw this image. So I think the procedure you're referring to is intracytoplasmic sperm injection, which is where we basically select 1 sperm cell to inject into an egg. This is the slightly different procedure, which is further along the chain of events. This is basically a procedure where we're using a micromanipulator to remove some cells from the embryo. What you see there is a morula, which is an embryo around days 3, 4, really. That's basically removing some of the cells of that embryo to performing a biopsy to then send them off to a special laboratory where these cells will be tested for their genetic makeup. So this is pre-implantation genetic testing, basically, that we're looking at, not so much ICSI. So let's go through these causes then. Ovulatory disorders. Now, the first thing to know about ovulatory disorders is that, which is not a very happy thing, is the fact that the passage of time does affect egg reserve. And we know that women are born with a limited number of eggs, and that number will just continue declining as time progresses. We know there are 2 times when that decline is perhaps a little bit steeper, and that's at the ages of 37 and then again at 40. But what's really important to retain is that it's not just a matter of a loss in numbers, it is also a matter of loss in quality. And we use quality as a very loose term for the genetic makeup of these eggs. And these graphs basically tell us the same story in different ways, really, because what graph A tells us is that if someone has been trying to conceive for 20 cycles, what that means is that the probability that they will conceive in cycle 21 becomes low, and then 22 even lower. So the longer people have been trying to conceive, the less likely it is that in the next cycle they will conceive. By the same token, graph B tells us that the longer people have tried to conceive, the more likely it is that in that period of time, they will have achieved a pregnancy. So that about 80%, 85% of couples will fall pregnant within 12 months. And out of those who don't, 50% will conceive in the second 12 months. So that cumulatively, after 24 months, we're looking at about a 95% pregnancy rate. So most couples will conceive within 2 years of trying. And the other thing we know is that as age progresses, then the ability of meiosis to be completed in a normal fashion decreases. And that stems from a number of factors, including, reactive oxygen species, for example, DNA damage. So all sorts of changes in the oocytes, in the eggs, but also the follicles surrounding those eggs. And it is for that reason that the risk of aneuploidy, an abnormal number of chromosomes in the embryo, increases as people become older. But crucially, one of the most important aneuploidies is Down syndrome, trisomy of the chromosome 21, which is of course compatible with life, but the risk increases quite substantially as people go beyond 35 years of age. And the same applies to other trisomies, like, Patau's 13 and Edwards 18. Can someone describe this diagram to me?
This is the follicular luteal phase of menstrual cycle.
Yes, that is very succinct. Do you have anything else to add to that?
Well, at first there's menses for 5 to 7 days.
Mhm.
There's estrogen starts rising, increasing the endometrial thickness, and there's the luteal surge, where the corpus luteum secretes progesterone, and then the endometrial starts innovulating and causing menses.
Yeah. And then what happens on the right-hand side of the graph?
There's ovulation.
There's ovulation, but then there's something else.
Conception happened. Or okay.
Conception happened. Yeah, exactly. So this isn't just one cycle. These are two cycles where on the left-hand side, conception doesn't happen, so fertilization doesn't occur. And what happens is the corpus luteum, once the egg is released, the thecam granulosa cells that are left behind will form the corpus luteum. And the corpus luteum is very important because it secretes progesterone, which will maintain the endometrium. But the corpus luteum has a limited lifespan. And I don't know about you, but I did medical school in Portugal and France, and when I remember vividly being in medical school and people saying that one of the dogmas of reproductive medicine is that the luteal phase, the duration of the luteal phase is fixed and it's always 14 days because that's the lifespan of the corpus luteum. I don't know if you've heard that, but if you have, that's a myth. And the reality is different corpora lutea will have different lifespans. And it is for that reason, a lot of the time that people will have different cycle durations, not just because the follicular phase duration varies. But on average, what we know is that the corpus luteum lives for about 12 days and then it sort of regresses into the corpus albicans. And we know that from pretty recent data and good data suggesting that, yes, you were taught that the luteal phase is fixed. Well, but the reality is it's not. It's not. I can tell you categorically that it's not. In many people, there will be some some regularity to the duration of the luteal phase, but I think you may one day find yourselves in a clinic where someone will come in and say, "Doctor, I have a really short luteal phase." And you'll find yourself thinking, "Oh, well, I'd certainly found myself thinking this. Well, no, you don't, because your corpus luteum lives for 14 days. What are you talking about?" Yeah. Well, there you go. So yes, so that's what you learned in medical school, and many women here complain of getting pregnant after the fertility period, just before the next cycle. Well, my suspicion is that if they have a short luteal phase, it may well be because, well, right before the next cycle might have well been around the time of ovulation, really. Wouldn't that also affect the way we calculate for the probable ovulation day? Yeah, it would. Absolutely, it would, because it assumes that. So when we look at the probable ovulation day, we're looking at 14 days before the next cycle, but the reality is that's not universal. It's most definitely not universal. And in fact, if you look at, so there's a good paper from the American Society of Reproductive Medicine looking at luteal phase defect. And luteal phase defect is something that, well, I do a lot of research on, and I'm really fascinated by this. But and yep, I won't go into it in a lot of detail, I promise. But luteal phase defect has been defined in many ways, even in the duration of the luteal phase. And then someone asks, is it fixed for each specific woman, but different from one to another? Well, there is more regularity in each woman, But no, there is also variation between the luteal phase duration of different cycles. And that's something that we've been able to see, even recently in a data set of thousands and thousands of women. It's very clear that not every cycle is the same. But anyway, the point is the corpus luteum is truly what determines cycle regularity. So it's not so much that people ovulate because they have regular periods. It's more the other way around. It is because people ovulate that they have regular periods, because it's by virtue of the corpus luteum regressing that estrogen and progesterone withdrawal happen and the endometrial sheds. So that's how important the corpus luteum is. But equally, if there is fertilization, which is what you see on the right-hand side, that corpus luteum is just as important in maintaining a pregnancy, because it is because of the progesterone and the estradiol secreted by the corpus luteum that the embryo will be able to implant on the endometrium. The endometrium will be receptive, and then the syncytial trophoblast will secrete HCG, which will nourish the corpus luteum. The corpus luteum will continue secreting progesterone that nourishes the endometrium. So you can see that they develop this sort of symbiotic relationship with one another, where without the other, you can't really carry on. Until about 7 to 8 weeks, when the placenta then takes over the endogenous secretion of estradiol and progesterone. So this diagram may appear simple, and my suspicion is that for a lot of you, it's perhaps too simplistic. And yet I think it's so absolutely paramount, because it really anchors our knowledge of the menstrual cycle and the impact of the corpus luteum upon not just people's cycles, but also pregnancy. And a lot of people come to the clinic asking, "Oh, when should we have intercourse?" And this circles back to that question that your colleague was asking earlier, which is, what is regular intercourse? Mohammed was asking. Sorry, I'm just reading a message about a WhatsApp group. I'm so sorry. I can't. For some reason, I'm not able to let people in or out of the meeting, because I don't think I'm an admin. I'm sorry. So I was just going to say that people ask, "Oh, when should we have sex?" Well, what we tend to tell people is that the best time, well, I generally tell people to start having unprotected sex from around day 7 or 8 of their cycle, because you never quite know when ovulation will happen. And because sperm lives in the female reproductive tract for 5 days, we would like sperm to be present already around the time of ovulation, because if not, what you find is that by the time ovulation happens, it may already be too late. So that peak actually happens, the peak fecundity actually happens 2 days before ovulation. Let's talk about some ovulatory disorders. I'm sure you'll all be familiar with this in terms of the hypothalamus secreting generation in a pulsatile fashion. Generate receptors in the pituitary then are activated and secrete FSH and LH. FSH and LH will act upon the growing follicle. Have you all heard of the two-cell theory? Can you repeat that note again? What note are you asking about? Sorry. A time for sexual intercourse. Yes. So I'll give you an example. A lot of people come to the clinic saying, "Oh, we're using LH strips to test ovulation," essentially urine tests that tell women whether they've had an LH surge. And the problem with that is that if someone is busy doing whatever at work or whatever, doing things during their day, and they come home and they test their ovulation and they find that the LH surge is there, there's no way to tell how long that LH has been present in the urine for. So there is a world where the LH surge might have started happening 12 hours ago. And if that were the case, that egg might have been released already. So there is an argument to say that by the time you test your LH surge and you have sex, it might be too late already. And it is for that, because the egg might have been released and missed the sperm. And it's for that reason that studies show that it's best to have sex around 2 days before ovulation is due to occur, because then you can guarantee that sperm will be present in the reproductive tract by the time the egg is released. I hope that's clearer. No worries. So yeah, FSH, LH, Yes, so the FSH, so granulosa cells secrete estradiol, and essentially what happens is what your colleague described earlier, which is the LH surge is triggered by increasing levels of estradiol, and then that leads to ovulation, and the corpus luteum secretes progesterone and some estrogen as well. When it comes to classifying ovulatory disorders, so the most universally used classification remains the WHO classification, although FIGO has an alternative classification where PCOS is its own entity. But essentially, for me, I think it's relatively easy or helpful to think about a cause of anovulation by thinking about when the pituitary goes wrong or the hypothalamus, which is something that leads to a decrease in FSH/LH, and the cycle stops because of that. And that can happen for a number of reasons, including a low body mass index, low body fat percentage. It can be associated with Sheehan syndrome as well, pituitary tumors. So anything that may actually lead to hypothalamic or pituitary dysfunction. And essentially that can be treated with HNG, which is a formulation. It stands for human menopausal gonadotropin, which is a formulation containing FSH and LH, which will then resume the cycle. The second group, or group 2, is the most common one, and it is marked by polycystic ovary syndrome. And essentially what happens in group 2 is that, PCOS is driven by, it's multifactorial. We know that. Genetics play an important role. Ethnicity plays an important role. Weight, people's weight is both a function and a consequence of PCOS as well, in many ways. And insulin resistance is hugely implicated in the development of PCOS. And it's something that we treat. Well, the first line should be letrozole, really, according to the latest international guideline on polycystic ovary syndrome. And letrozole is usually given from days 2 to 6 of the menstrual cycle. The dose varies between 2.5 up to 5 or 7.5 milligrams once daily. Historically, we used to use clomiphene citrate, which some centers still use in the UK. And we're just finishing the largest trial ever comparing the two drugs actually in people with PCOS. That's something that will come out later this year, comparing clomiphene to letrozole, but also looking at the effect of metformin on PCOS. And group 3, ovulatory disorders, involve essentially POI, so ovarian failure. It affects, fewer than 5% of the population, and it can be caused by various issues. So most cases remain idiopathic, and some cases are due to gonadotropin treatments like chemo or radiotherapy. But of course, there are genetic syndromes that can also lead to ovarian failure.
I'm sorry to interrupt. Can I ask a question? Is there like another cause of Sheehan syndrome other than bleeding? And can it happen with other bleedings other than postpartum?
So Sheehan, so my understanding of Sheehan's is that by definition, it is caused by pituitary apoplexy following a massive obstetric hemorrhage. So I'm inclined to say no, I don't know of any other causes. But I guess if there is, overwhelming hemorrhage from whatever other cause, like trauma, for example, then it's not unreasonable to postulate that Sheehan could develop as well.
Okay, thank you.
No worries. Okay, does anyone know what we use to diagnose PCOS?
Usually clinical, because it's mostly caused by overweight, or like the most common cause is overweight and high insulin secretion. So it's probably clinical. Then they can test the hormones, FSH, LH, and testosterone to actually diagnose it, investigate by investigation, and ultrasounds, of course, when you can see the necklace appearance and other symptoms.
Yeah, so got hirsutism on the chat. Does anyone know what sort of criteria we use? As in terms of there's a set of criteria that have
Rotterdam.
the Rotterdam criteria, exactly. And the Rotterdam criteria, there are 3 of them, and 2 of them are necessary to make a diagnosis of polycystic ovary syndrome. And I guess the most obvious one is polycystic ovary morphology on scan. But that's not necessary to have a diagnosis of polycystic ovary syndrome. So the other 2 would be oligo or anovulation, so fewer than 8 cycles per year, or 8 periods, but also evidence of clinical hyperandrogenism, like you were saying in the chat. So acne, hirsutism, alopecia, and also biochemical hyperandrogenism. So a high testosterone, not too high, hopefully, but high testosterone, and yeah, and low SHBG as well. Signs and symptoms. So, I mean, this is general knowledge, which for most of you will have heard about. In terms of symptoms, you mentioned obesity, hyperandrogenism, we mentioned already, menstrual disturbances, infertility by virtue of not releasing an egg. And also in terms of endocrinology, we've spoken about what to look out for. When it comes to FSH and LH, so usually the ratio of FSH and LH is inverted in these patients. So usually you'd see in people without PCOS, you'd see an FSH that might be slightly double that of LH or 1-to-1 really. But with PCOS, a lot of the time we see elevated LH, so double in the amount of LH compared to FSH. Ibrahim.
Dr. Pedro, Dr. Pedro, I want to ask you about the first criteria in Rotterdam criteria.
Of course, yes.
So they say it says the oligo or anovulation. So this is different from oligomenorrhea or amenorrhea, yeah?
Yeah, that is a good point, actually.
And how can we differentiate practically when we want to take history, for example?
Yeah.
I have talked the rotation of Obs and Gynae. This has been mentioned, but I forget it. So I want to ask you about it.
Yeah, that's a really good point, actually, because I think the 2 are very much related to one another. So oligomenorrhea and anovulation, because, as I was saying earlier, the reason people have periods is because they've released an egg, most of the time, really. Not always like that, but I would expect that if people are having fewer than 8 cycles a year, what that means is that they're not ovulating regularly, but they will be experiencing some degree of either breakthrough ovulation or hormonal withdrawal. So I'd be tempted to not make a huge distinction between the 2, but I guess it is possibly reasonable to expect that if you don't release an egg, you're not hugely likely to have a period, although that's not always the case.
Yeah, there is a term that's called an ovulatory period. Yeah, it is a period without ovulation. Yeah,
Yes.
that's the term in Obs and Gynae.
Yes, and that can happen. Of course it can, but it happens by virtue of the endometrium not receiving sustenance from estradiol or progesterone, or both. So it's hormone withdrawal, which is not dissimilar to what happens in people who are, for example, postmenopausal and experience endometrial atrophy and bleed because of that. And similarly, I mean, there are people with PCOS who have endometrial hyperplasia, for example, and can experience bleeding because of their hyperplasia. So you're right. I mean, one is not synonymous with the other.
Maybe you
questions
can discuss this, or I get the answer later.
Yeah, definitely.
Yeah. Thank you, doctor.
No worries. Okay. So things that we do for PCOS, does anyone know what sort of measures we recommend to people with PCOS to improve their fertility?
Mostly
weight
lifestyle
loss.
modifications.
There's
Yeah.
weight loss and there's exercise, metformin and letrozole for ovulation.
Yes. And do you know how letrozole and clomiphene, letrozole, metformin, and clomiphene work?
They're mainly used for diabetes, so they are usually used to treat the hyperinsulinemia that is caused by too much sugar or like insulin resistance. So that's the mainstay. And
Yeah,
they cause
that's
weight
what.
loss.
Yeah, so that's what metformin is used for. So so to reduce insulin resistance for sure in these patients, and yet metformin is known to facilitate ovulation, but it's not really first line treatment in people with PCOS. You're right. In some people, it will facilitate weight loss, but in terms of metformin for ovulation induction, it is generally not used in isolation. We tend to prefer, well, the first line should be letrozole with or without metformin. And how does letrozole work? Does anyone know?
I think it's aromatase inhibitor, decreasing
It's an aromatase
estrogens,
inhibitor.
increasing feedback.
Absolutely. And you're absolutely right. So what it does is in some ways it tricks the pituitary gland to think that there isn't enough circulating estrogen peripherally. So then the pituitary starts secreting more FSH. And so it is an aromatase inhibitor that works peripherally. How about clomiphene?
It's a partial antagonist on the pituitary gland, right?
Yeah, it is a selective estrogen receptor modulator, which acts on the pituitary gland. You're absolutely right. And it does more or less the same as letrozole in sort of tricking the pituitary into thinking that there isn't enough circulating estrogen, but it works centrally. So then the pituitary secretes more FSH in response to that. What happens, and crucially, so the regimens for letrozole and clomiphene are very similar to one another. The difference, I alluded to the letrozole regimen earlier in terms of giving drugs from days 2 to 6. With clomiphene, it's similar, but instead of 2.5, 5, or 7.5, we give 50, 100, or 150 milligrams. What happens if these drugs don't work? What do we do next?
They're at risk of ovary stimulation syndrome, which is an emergency.
Yeah, there are, but so it's not common for people to have OHSS with clomiphene or letrozole. It's not very common. It happens more when we give them something else.
Do we look for central causes?
Central causes of what, sorry?
Like there's like no hormones, whether LH or FSH, from causes centrally problems in the pituitary or like hypothalamus. So we try to look for these things to treat them if they are the cause.
Yeah, you can do, and for sure, and that's part of the workup that you should do for people with infertility. I'm more asking about what to do in people with PCOS when clomiphene, metformin, letrozole don't work. What else is available?
IVF.
Yeah, IVF. And before that, what might you consider?
Maybe insemination.
Well, that's a good point, actually. So, are you thinking about intrauterine insemination? Is that what you're thinking?
Yes.
You are. Well, yes, sometimes you can use that, particularly in people who can't achieve, penetrative vaginal intercourse. Yes, sometimes we can use ovulation induction and IUI at the same time. I'm more thinking about ovulation induction with gonadotropins, so FSH, LH, HMG, and also something that we surprisingly still do in some cases, which is laparoscopic ovarian drilling. I don't know if you've heard of it, but it is something that is thought to kickstart the ovaries and sort of like regulate them or force them into self-regulate pretty much. Okay, good job. And IVF is always available, you know, well, it's not always available, but it's always like the end of the line. It's always like the third line therapy for all sorts of problems that people might face when it comes to infertility. Now, let's talk about group 3, premature ovarian insufficiency. We've spoken about it already, haven't we? We said that, you know, diagnosed before the age of 40. So FSH levels are usually what we tend to utilize for the diagnosis. Ultrasound can be helpful, but it's not going to be hugely helpful in terms of telling us what the cause is. It might tell us that there is a low anthropoidal number, and that is helpful. Now, importantly with POI, well, people with POI lack estrogen, and we know that estrogen is incredibly important for what reasons?
Other than infertility, bone health, I guess, like the strength of bone is better with estrogen. When we talk about menopausal women or like menopausal women, so they are important in bones.
Absolutely. So bones, heart, brain. That's what estrogen is most important for in premenopausal women. I'm sorry. And it's for that reason that if people have POI, it's really important to provide them with some sort of exogenous supplementation, either in the form of HRT, which we generally tend to prefer, or the combined oral contraceptive, which of course contains more synthetic hormones. But to date, there are no studies categorically demonstrating a difference in terms of bone, you know, cardiovascular and brain protection between the two. So HRT and the combined pill can be used with non-inferiority between the two so far. DEXA scans to look at bone health and investigate for osteopenia and osteoporosis. And of course, ultimately, people trying to conceive with POI will have to rely on IVF. There is still a 5% chance of conceiving naturally, though, in POI. So if someone has POI and doesn't want to conceive, then the right thing to do would be to put them on contraception. What sort of investigations would we use for ovarian reserve markers? Which ovarian reserve markers do you know?
AMH.
AMH, which is secreted by what? Which cells in the ovary?
Can you repeat the question, please?
Granulosa cells.
Yes. The question was which cells in the ovary secrete AMH, and the granulosa cells is the answer. Okay, so serum AMH. What else?
The ducts, I think, the degeneration of the ducts during development in the early ages.
That's true, yeah. FSH, yeah, someone said FSH. And LH. When do you measure AMH, by the way? When in the cycle do you measure AMH?
Your question about the time?
Yes, timing of the cycle.
Yeah, second or third day of the last menstrual period, I think.
So Shahad is right. Shahad is saying that it doesn't really matter. It can be any day. Yeah, and I agree. For AMH, it doesn't matter. It can be done any day of the cycle. But I agree with you, whoever was speaking just now, that if you're going to do FSH and LH, then days 2 to 5 of the cycle are the best time to do it. And what other markers of ovarian reserve do you know? An ultrasound marker. Do you know an ultrasound marker of ovarian reserve? One that we use pretty universally is the anthrofollicle count, which is something that Omar is just, yeah, and Misan are just alluding to. Yeah, and I agree. And how do we test ovulation?
Does estradiol also count as a
We don't tend to use estradiol anymore. We use estradiol for different reasons. For things like, because we know that estradiol levels fluctuate, we tend to use estradiol levels as a marker of people's absorption of estrogen when they are on HRT instead. But you're right; it is something that
okay.
historically people have used in the early phase of the cycle, early follicular phase. People have used.
And I guess that goes also for inhibin B because it's
Yes,
like
inhibin B.
used.
You're absolutely right. It's no longer used routinely. We wouldn't. So if you look at the European guidance, they recommend that you should consider ovarian reserve based on people's age, AMH, and androgen follicle count. And that's generally what we tend to do. FSH, yes, as well, because FSH then has that nuance of also allowing us to diagnose POI if it's high. Do doctors still consider wedge procedures for PCOS? Well, I haven't seen that done in the UK ever, I should say. And in fact, even ovarian drilling, I was surprised to hear that a colleague of mine did one the other day, because it's just not something that we would do routinely. I mean, particularly these days when it's really surgical waiting lists can be very long. So it's not something that we do very often. Ovulation. How do we test for ovulation? So we test for ovulation with something LH level. So, well, an LH level tells us whether an LH surge has happened. It doesn't tell us whether an egg has been released. FSH LH ratio, still not reliable enough.
By ultrasound.
Ultrasound, what are you going to find on ultrasound?
A bulge on the ovary, then rupture. Maybe we see this.
Yeah, I mean, you might, but I think there is something else that you will find on ultrasound.
Corpus luteum.
Absolutely, a corpus luteum is what you're going to find on ultrasound if there's been ovulation. Although the fact that a corpus luteum exists only tells you that there's been some degree of luteinization of the theca and granulosa cells. It doesn't really say that an egg has definitely been released, because who knows where that egg is going. And you're also right, Razan, that progesterone secretion is something that we use to test for ovulation. But ultimately, what is the absolute test for ovulation? What is the absolute proof that someone has ovulated? Mittelschmerz. Well, yeah, Mittelschmerz is a pain that you get mid-cycle, which is a pain from ovulation. No, your body temperature goes up a little bit with progesterone, but it doesn't quite reach fever levels. The only categorical way of knowing for sure whether someone has released an egg that's gone into the fallopian tubes is getting pregnant, Samira. You're right. I agree entirely. Getting pregnant is the absolute proof that someone has released an egg into the right place. The rest are proxy markers and tests that we use. So, yeah, so the preferred for ovarian reserve markers would be anti-Mullerian hormone, androgen follicle count, and also you can use FSH and LH, of course. And for ovulation tests, we use serum progesterone. But as you said, I want to say it was Ibrahim who said this, a corpus luteum also indicates that luteinization has happened on ultrasound. Tubal damage. Tubal damage affects about 1 in 5 people. Causes of tubal damage. Can anyone name some of them?
Chronic PID that causes adhesions.
I agree. Yeah, what else?
Tubal structures or adhesions.
Yeah. So Asherman is not really a tubal condition. Asherman is an endometrial condition, which is caused by scarring in the endometrium, which then leads to amenorrhea. Pelvic inflammatory disease, yes. The PID, which your colleague already said, leading to scarring. Previous ectopic pregnancy, that's very true. I love the bold text, that's correct. Previous ectopic pregnancy, previous tubal pregnancy, yeah, that's correct. So if people have had a salpingectomy before because they had an ectopic, inevitably they will be missing one tube. And if they have had 2 ectopics in the past, which is something that's, so the baseline risk of someone having an ectopic pregnancy is about 1%. If someone has had an ectopic pregnancy on 1 tube, then the risk of having another ectopic pregnancy increases by 10-fold, so it becomes 10%. So yeah, absolutely. So these are some of the conditions that can lead to tubal problems. So scarring, previous ectopic, inflammation because of, for example, appendicitis, bilateral tubal ligation for contraception, people who go through the regret of having had contraception, and also large uterine fibroids as well. Congenital malformations, absolutely. Loss of cilia function, also true. I was going to ask you, sorry, I just jumped the gun there. I wanted to ask you what investigations you would use to test for tubal patency.
We usually know sometimes by beta HCG markers when they don't elevate as they should. So we might think, oh, this might be an ectopic pregnancy with the pain. It might be bleeding, abdominal pain, and other symptoms.
Sorry, you lost me because I forgot what questions I had asked. I thought that, so I was asking a question about how to test for tubal patency.
Oh, sorry, I thought ectopic pregnancy.
Oh no, okay, that's what I was thinking in my head. Sorry. But you're right in what you said about ectopic pregnancy. Yeah, I think colleagues are saying it's just salpingogram. It's just salpingogram, saline infusion. So saline infusion, we don't tend to use saline infusion for tubal patency, but we use contrast-based tests on using ultrasound as well. So firstly, we test for chlamydia, and before we do any invasive tests with dye. And then Hycosi is an ultrasound-based test where we inject a water-based dye through the cervix. And hysterosalpingogram is an X-ray based test where we use an oil-based contrast and then X-ray the pelvis. Ultimately, the gold standard is a laparoscopy and dye test. So I'll take you through some of these. So here you see a transvaginal ultrasound scan, which is, what we use for Hycosi, where we then instill some dye through the cervix, and then you can see on ultrasound whether the dye has come through. This is a hysterosalpingogram with X-ray. Can anyone describe this image to me? What do you think?
On the left side, there's probably a problem, I would say. I'm not sure what it is, but the dye is not there enough, like with the right side, comparing it to the right side.
So, okay, so when you look at this image, so the patient's, which of the patient's side is normal and which isn't normal?
I think the right is abnormal because it has been pushed, the uterus pushed to the left. There is a enlargement in the ovary maybe, or the fimbria of the fallopian tube. Maybe, yeah.
Okay. Does anyone have a different opinion? Someone said right hydrosalping, someone said both abnormal.
The left is abnormal because there's filling defect in the left.
You think? I think the left looks perfectly normal in terms of filling and fill and spill, really, and spillage. I'm more worried about the right tube, really, because what I can see here is that there must be some degree of distal obstruction, whereby what you see is as you instill dye, it doesn't really extravasate into the pelvis, and instead it accumulates into what is like a sausage-shaped structure. So it's effectively a hydrosalpinx, really. So I think here what we're dealing with is a right-sided hydrosalpinx and distal tubal obstruction, whereas the left side appears perfectly normal to me. That's what I would say if I had to look at this image and interpret it. With a lap and dye, this is what you see. You see blue dye come out of the tube through the distal end, and which has been injected through the cervix. Okay, I'm conscious of time, so we're going to move on into uterine or peritoneal disorders. So polyps, fibroids, I'm sure you're all familiar with what polyps and fibroids are, and of course the field classification for fibroids. When it comes to an association with infertility, we know that polyps measuring over 1 to 2 centimeters can cause or can be associated with infertility. Fibroids, well, mostly if there are submucous fibroids, type 0 to 2, large intramural measuring more than 4 centimeters, or sometimes subserosal fibroids or fibroids types 2 to 5, measuring more than 7 centimeters. And the problem is not so much that we know that polyps and fibroids are associated with infertility. The problem really remains the fact that we don't know whether removing polyps and fibroids actually improves people's fertility. So that's something to consider. Endometriosis, so ASM classification of endometriosis. I'm not going to go into this into a huge amount of detail because, well, firstly, because I feel like I spend a lot of my time talking about endometriosis, and I just spent a whole day operating on people with endometriosis, so it gets a bit repetitive. I guess with endometriosis, the thing to retain is that number one, it can be a cause of tubal pathology. Number two, symptoms don't correlate with disease extension or surgical classification, if you like. Number three, if you're thinking about the impacts on treating endometriosis on people's fertility or improving their infertility, that if they're trying to conceive naturally, there's only a benefit in surgical excision in people with stages 1 or 2 endometriosis. In stages 3 and 4, there is no benefit to natural conception from removal of the endometriosis. And if people are going to have IVF anyway, there is no point undertaking surgery for endometriosis unless it is because they have, for example, large endometriomas or the ovaries are high in the pelvis and not accessible with IVF. So just some aspects to retain from endometriosis treatment. Male infertility. Okay, so can anyone tell me a little bit about pretesticular, testicular, posttesticular causes?
Yeah, pretesticular, like gonadotropin insufficiency.
So what are you going to see on your blood test?
Blood tests. No idea, but maybe no testosterone. No idea for me. Yeah.
No, but you said something that was right. You said low testosterone. And why is the testosterone low?
Because the testes are not developed. They didn't form, so there will be no testosterone, maybe.
Well, not necessarily, actually. I mean, the testes could still be developed, but if there's no drive, so spermatogenesis depends on which hormones.
Yeah, of course, testo. So, LH.
What else?
And FSH for Sertoli cells.
Yeah, so as FSH for Sertoli cells, LH for Leydig cells, but also testosterone is important for spermatogenesis. So if you have a low testosterone in a pretesticular case of, let's say azoospermia, then you're going to have a low FSH and LH, and that's effectively low FSH, low LH, low testosterone. Basically, make a diagnosis of pretesticular causes, which could include, tumors, Coleman syndrome. Sometimes drugs like anabolic steroids, for example, and systemic illnesses, even cancer, for example, and chronic illnesses can lead to pretesticular or azoospermia. How about testicular? What are you going to see in your blood tests? Causes that are intrinsic to the testes.
Torsion, maybe?
Torsion. Yeah, torsion can lead to testicular failure for sure. What else?
Varices, testicular varices.
Yeah, I will. Yeah, testicular, post-testicular. Yeah, varicocele. Some people would consider that post-testicular, but they can be testicular as well.
There's like one reason, but I think it's more of post-testicular, which is cystic fibrosis when it causes occlusion to the vas deferens.
Very true. Cystic fibrosis. So if someone has cystic fibrosis, I guess cystic fibrosis is not a perfect example because a lot of the time when people have cystic fibrosis, they have some issues with sperm production as well. Although, the problem with cystic fibrosis is the congenital absence of the vas deferens bilaterally, which then leads to sperm being formed and produced. It just doesn't make its way out of the male reproductive tract because of the absent vas deferens. But in testicular causes, what would you expect to see with your testosterone, FSH, and LH?
We have low testosterone, but high FSH and LH.
Yeah, that's what I would say. Yeah, because the pituitary is trying to compensate or overcompensate for the fact that testosterone is low. And in post-testicular causes, what would you expect?
Both are normal.
Yeah,
Absence
exactly.
of vas deferens?
You are correct, sir. I agree entirely. So this is more or less how I would classify things, in terms of pre-testicular, testicular, and post-testicular, and their impact on, or their causes, basically. Male infertility investigations. So this is just a little, yes, definitely. It could be considered as a cause of infertility, past history of undescended testes. So when it comes to infertility baselines from the male partner, usually we start off with a seminal fluid analysis, which is a semen analysis, and the WHO criteria for semen analysis have evolved over the years. Currently, the main criteria include sometimes CKD can sometimes cause infertility through its systemic impact. The volume of the semen analysis of semen that we would expect would be at least 1.4 milliliters. The concentration we hope for is 16 million per mil or above. The total motility should be 42% with progressive motility of 30%. Progressive motility includes grades A and B, which involves the sperm that is wriggly and moves forward. And then morphology is the final parameter that we focus on. And we know that nature is not terribly forgiving to sperm. Only 4% of them need to be normal for males to have normal reproductive potential. So the main factors to consider are volume, concentration, progressive motility, and morphology. And if there is a reduction in these parameters, then we can undertake additional investigations, particularly where there is severe oligospermia, so fewer than 5 million per mil in the ejaculate, where we then look for FSH, LH, testosterone to look for the causes we just alluded to, but also prolactin and TFTs, because we know that prolactin disorders and thyroid disorders can lead to an abnormal semen analysis. Ultrasound of the testes to look for things like varicoceles, for example, testicular volume as well, and then karyotyping for things like Klinefelter, which was present in the previous slide, and chromosome Y microdeletions testing. Why do you think testing for chromosome Y microdeletions is important?
There will be a problem if there is Y chromosome deletions, a specific. And also karyotype is very important because some syndromes cause infertility in male.
Yeah. Chromosome Y microdeletions are particularly important because the Y chromosome really is the main chromosome where the genes that regulate spermatogenesis exist. That's one thing. And depending on the type of microdeletion we have, in people with severe oligospermia or azoospermia, that gives us a prognosis or an idea of the prognosis as to whether we're going to be able to obtain sperm through surgical sperm retrieval or not. The other impact this has is as you know, a male person will pass on a Y or a Y or an X chromosome to their progeny. And if they pass on a Y chromosome that has microdeletions, that will inevitably have impact upon their male progeny as well, which is the reason why people with chromosome Y microdeletions should not just be diagnosed, but also undergo genetic counseling, sorry, so that they know about the implications of having male children in these circumstances. And if there's no sperm, then these people should be screened for cystic fibrosis as well. Okay, so then there's a bunch of cases which I have, my sense is that I possibly could send you more of these cases in addition to the ones you already have. I could make this into a PDF and then you can work through these cases on in your own time, I think, because there's quite a lot of them. So this is not dissimilar to what you have in the workbook that I've sent you. But it just goes through, what questions to ask, what investigations to undertake, and there's going to be 2 or 3 of them. How much time does the patient need to avoid intercourse before doing the test? So for a semen analysis, between 2 and 5 days. You don't want to leave it too late, but also you want to give the testees time to recharge. Assisted conception. We're going to spend the next 5-10 minutes talking about this before I let you go. When it comes to assisted conception, well, what sort of assisted conception technology do you know?
Insemination and IVF.
Yeah, those are the 2, I agree. Those are the 2 main ones. So intrauterine insemination and in vitro fertilization. Who would benefit from intrauterine insemination? This is what it looks like, by the way, intrauterine insemination. We use a little catheter that we thread through the cervix, and then we deposit the semen sample.
Maybe those who have impotence or erectile dysfunction, psychogenic.
Yeah, so erectile dysfunction for sure. People in same-sex couples, so same-sex female couples as well. People with who are, with some sort of vaginismus, for example, or inability to have vaginal penetrative intercourse, they can have intrauterine insemination. So this has a little summary. So unable to achieve vaginal intercourse, sometimes with blood-borne viruses as well, donor insemination, single women who seek treatment with donor sperm, unexplained infertility. There's a growing movement towards offering people with unexplained infertility intrauterine insemination. And the argument is that with IUI, you're bypassing the mechanical barrier that the cervix constitutes, essentially. And that can be quite a big hurdle, that cervix. And we alluded to this earlier, actually, in IUI, which in the context of PCOS, people can have either gonadotropins or Clomid or letrozole. And then IVF. So IVF is quite a phenomenal technique, really. It's something that was developed in the 1960s until it became successful eventually in 1978. And Louise Brown is a British woman who has made a life out of having been the first IVF-born child. And does anyone know what the problem was with Louise Brown's parents? What was the problem? What was the cause of infertility? Are there any guesses?
We're not very familiar with that name, to be honest.
What was that? Sorry.
We're not very familiar with that name, or at least me.
Okay, yeah, no, fair enough. No. Sorry, I guess the name is less important, actually. It's more to illustrate the fact that the first baby born out of IVF was born in 1978, really. And since then, we've got at least 12 million, and we anticipate that by the end of the century, we'll have at least 100 million. So it is rapidly growing. The question I was asking was, why would someone need IVF, I guess, is the question. Why would someone need IVF? And in the case of Louise Brown's mother and a lot of women who were having IVF in the 70s and then 80s, and of course to this day, IVF was initially created because of people who had blocked tubes. Because what they thought was, well, why, if the fallopian tubes are blocked, why don't we find a way of mixing the sperm with the egg outside the body and then pop it back into the womb? And that is the reason why IVF was created, really. So very clever people thought about that. In the early days, we didn't used to stimulate the ovaries, but then we started doing so because we realized that the more eggs we get, the better it is, because the more embryos we have. So it is then possible to have several rounds of treatment. And what you can see here in this diagram is that IVF involves mostly, well, number one, ovarian stimulation, then retrieval of the eggs with something that looks like this. So it's a vaginal probe with a little attachment. Through it goes a needle. And what we do is the needle goes through the top of the vagina, reaches the ovaries, and then goes into the follicles. And then there's a suction pump, which is controlled by the operator's foot. And as we press on the pump, the fluid is drained from the follicles, and in that fluid, we hope there will be eggs. And then those eggs are fertilized outside the body, and they can be fertilized with conventional IVF, where we leave each egg, or 2 or 3 eggs really, in a petri dish overnight, or with ICSI, which is what I was alluding to earlier, which is where we just use 1 sperm to inject into each egg. And then once fertilization has happened, we leave the embryos inside an incubator for about 5 days. And then on day 5, we select the best looking embryo to pop back into the uterus. And it's almost like having a smear test. So a little catheter threads through the neck of the womb and then leaves the embryo inside. And then about 50% of people who have IVF end up having surplus embryos. And these embryos can then be frozen to be used in future treatment where necessary. We know that people who have IVF suffer with some degree of luteal defect, which is the reason why we give everyone progesterone after a fresh cycle. And then usually a couple of weeks after the embryo transfer, people will do a pregnancy test. And if it's positive, they'll continue the progesterone until they have their first scan. If it's negative, then they'll stop their medications and then have a bleed shortly after, so a withdrawal bleed. This is the egg collection procedure. It's got some more information, but nothing terribly relevant. In terms of success rates, so it's interesting because the success rates of IVF hover around about 1 in 3, but even then, it really is best case scenario if you think about it. So the younger population are the ones with the best prognosis, and the prognosis inevitably becomes worse as time progresses, so that when people are aged between 43 and 50, I've never seen anyone aged 44 or over achieving a live birth with their own eggs in IVF. Inevitably, people at one point will start transitioning into donor egg treatment around the ages of 43, 44, really. But if they were to conceive with their own eggs, the success rate is lower than 5%. Multiple pregnancy is a big thing because the morbidity that comes with multiple pregnancy is huge in terms of prematurity, growth restriction, and also maternal complications such as preeclampsia and the risk of cesarean. So in the UK, we have a law where all IVF units are obliged to keeping their multiple pregnancy rates to less than 10%. And at the moment, it's about 5 or 6% really. And we achieved this by starting to transfer 1 embryo only each time. Oh, sorry. There's a question about when do they do gender selection? Do they karyotype the zygote itself? No. So gender selection is something that is illegal in the UK. It's legal in many other countries, like the US, for example. But in the UK, we're not allowed to do gender selection unless it is for X-linked disorders. So that's when we are allowed to do selection of embryos based on sex, really. Ovarian cancer, yeah, no association between ovarian cancer and IVF. And then people worry about the ovarian hyperstimulation syndrome risk, which is something that we know we've become better at mitigating by giving people short antagonist protocols. And then I created a little summary with what you may want to consider as treatment according to each person's, or what the diagnosis is. And then there's a couple more slides for cases where I just basically take you through the cases, and you're very welcome to go through them. I'm very happy to share these slides. It's not a problem. And that's it, really. That brings me to the end of the lecture. It's quite exhaustive. It's quite it's extensive. I'm very happy to take questions if you have any.
Thank you very much for the lecture, Doctor. It was really informative.
No worries. Thank you. Are there artificial uteri for IVF available? No, not yet. So we're trying to develop some organoids here in Oxford, which is, lab-based stuff, but we're very, very limited still. So we're limited to cells, organoids that are just endometrial cells being cultured. What we started doing here in Oxford recently is uterine transplants, and that's something that is a whole other level of, discussion.
Thank you, Doctor.
No worries. I will try and look up the answer to that question, Ibrahim, and then I'll get back to you. All right. Yeah. Have a good evening, everyone, and I will see. Well, I don't think I have any other lectures planned for you, but I wish you all the best. And free Palestine.
Thank you so much.
Thank you very much.